Good afternoon, everyone. I'm going to give it just 1 second because people are still trickling in here. Wonderful. Thank you for joining us at CNS Connect webinar series. My name is Amy Smith, and I am the Senior Director of Certifications and Advocacy at the ANA. And today I am joined by Megan and Ashley for the final webinar of the year within their series, where we're going to talk about how to review medical labs with nutrition in mind. As a reminder, if you're a CNS, you'll earn 1 CE for today's presentation. So I'll put a link in the chat towards the end so you can fill that out and get your certificate. If you have questions, feel free to put them in the Q&A or the chat, and we'll look at those throughout the presentation and then save some time at the end. So let me introduce you to our speakers. They've joined us several times this year. Megan is an experienced functional medicine provider, a CNS, research writer, public speaker, and educator for over 10 years in the field of nutrition science and functional medicine. She is the co-owner of BioLounge, a functional medicine clinic in Portland, Oregon, and co-founder and product developer of Fluorosophy, organic soluble fiber blends. In her clinical practice, Megan works to resolve underlying nutrition, infectious and inflammatory triggers, leading to reversal of chronic and systemic symptoms while promoting health and longevity. She combines an extensive health intake alongside comprehensive lab testing and an in-depth patient education to improve immune function, reduce inflammatory factors, optimize metabolic function, and reverse symptoms and disease risk. Additionally, she works as a CNS supervisor to support CNS candidates. Ashley is a functional medicine provider, a CNS, and an educator who works with teens, adults, and children and provides in-care, person, and virtually. In her clinical practice, Ashley works with clients to identify and address digestive issues, inflammatory triggers, nutritional deficiencies, gut health, and immune health to reverse their chronic disease states and symptoms. Her passion lies in identifying inflammatory triggers, addressing biochemical imbalances, preventing and reversing neuroinflammation, reversing autoimmune states, and mitigating autoimmune events. She utilizes evidence-based laboratory testing and an in-depth intake process, and her ability to make personal connections that allow clients to feel seen and heard in their chronic disease story. Ashley leaves clients feeling that they are in the driver's seat of their health journey and with lifestyle knowledge to take them beyond their time interacting with her practice. Megan and Ashley co-developed the BioLounge Clinical Immersion Program, a 3 months or extended 12-month program built to bridge the gap between your education and clinical practice for master's level nutritionists while providing CNS supervision, continued education, community, and functional medicine experience. So I will turn it over to Ashley and Megan. Let me stop sharing here.
Thank you. I'm going to work on sharing our screen. Are you seeing that?
I think you'll have to. Yeah, we can see it.
Different view, maybe. Hold on, we're working on our view. Technical issues over here. Why is it in thumbnails? Yeah. Single page. All right. Do you see one slide right now? No.
We can also see your left slides as well.
Yeah. All right. We're gonna stop
there
sharing.
There should be a slideshow. Sorry, guys. We're using a different program, so bear with us with our, oh, right there, slideshow.
Slideshow. All right. Now I'm here to share. Okay. View slideshow. All right. We did it.
Okay.
How's that?
Good. All right. So thank you for, oh, is it going to go on its own? It just moved on its own. Okay, we'll see, guys. This is, oh, it's an adventure. Okay, let's see. We're going to start here. We're going to try this again. Okay, so hopefully this behaves itself. So today we're here to talk to you about how we review medical labs in our clinic, keeping nutrition in mind. Obviously, we're looking through the lens of nutrition and in our case, functional medicine, looking at all the factors that may be affecting the markers that we're seeing on the page. So that's what we'll dive into today. We're excited to talk about it. It's a huge part of our practice. I don't probably need to do any more than you've already heard about me. So we'll just move past that. Ashley, anything else you want to say?
No, I'm
okay. Good. You guys know us now. Okay. So I have a quote here And it is by looking at only one place, you miss everything in all the other places. Look everywhere to see everything. And I think this encapsulates how we work to practice in our clinic, whether we're looking through the lens of symptoms, a patient's history, or looking at their biomarkers. And one of the things that we notice when we're collaborating with medical providers is that the way we look at medical labs is vastly different than how they're looking at them. And so we feel like it adds benefit to the patients to have multiple lenses, and we work really hard to explain to them what the laboratory marker actually means from a potential imbalance or dysregulation in the system. You want to start with that?
Yeah. So before we dive deep into what we're looking at and what it means, we're going to give you a picture of our overall panel. So typically we work with clients and we run a comprehensive medical panel. Not every client gets it, but as we're sitting through with our clients, we get a sense of who might need it and what data they're coming in with. And so in our comprehensive medical panel, we're going to review what's there and then we'll talk about it in more detail. For us, there's two ways we can get it. We might work with our client and say, I'd love to see a comprehensive medical panel, and here's a list of what I want to see, and they can ask their primary care physician or whoever they're working with if they can get access to one. And then if that's a lot of work and that's not something they want to pursue, then we can run a comprehensive medical panel cash-based. And so we have our custom panel we create and we can order. And right now we're doing that through a lab called Vibrant America. But there's many options out there if you want to do something like this. In our comprehensive medical panel, we can include a CBC with differential. We include a CMP. We're going to check a lot of markers around iron, so ferritin, iron, and all of these additional markers. We're going to check vitamin D, B12, zinc, and copper, and magnesium. And then we do a hormone panel, so looking at estradiol, testosterone, free testosterone, DHEA, as well as cortisol and progesterone. And then we look at blood sugar, A1C, fasting insulin, and triglycerides.
So in addition to that, we look at all of the lipids. So total cholesterol, you may be used to LDL, HDL. We also look at ApoB, and then we do a one-time look at Lp(a). That's genetic, so we don't typically retest that every single time. We have a pretty comprehensive thyroid panel, TSH, T4, T3, free T3, free T4. We look at 2 antibody levels and then reverse T3. And then we look at all 4 of the primary immunoglobulins to see if there's any downregulation or upregulation of antibody activity. We look at uric acid, GGT, and then some additional inflammatory markers, homocysteine, high sensitivity CRP, and OX-LDL.
Yeah. And I think it's also important to mention that we don't typically use reference ranges as our end-all be-all. So we definitely, in all of our educations, have learned a lot about what is optimal and what these reference ranges mean. And so we also are going to look at these labs in a different lens. So sometimes they're going to come from a traditional practice and they look at reference ranges, and we're going to educate them a little bit more on how they reach optimal levels and what optimal looks like as we're going through their labs. Yeah. All right, so one of the first things we're looking at is the CBC. And so highlighting a few things that really stand out to us when we're looking at our CBC. One is white blood count. So when we're looking at white blood count, there's some trends that you're going to see. So if you see someone who has low white blood count, we're thinking about chronic infections. That could be viral, that could be bacterial. We're thinking about the liver and what's going on there. We might be considering some nutrient deficiencies like B12, copper, zinc, vitamin D, and folate. And then if we see someone who has high white blood count, we might be thinking about an acute infection. It could indicate cancer. This might be someone who's using steroids. And so we're going to ask some clarifying questions around those things. When we're looking at red blood count, so we're thinking about what are the red blood cells doing? What are they missing? And so low red blood count could be an indication that someone has something going on with protein, hypochlorhydria. I can never say that one. We will be thinking about iron, copper, zinc, and various factors that could be contributing to that, as well as thinking about food allergies. Does this person have any concerns with digestive health? Are there any digestive symptoms coming forward? It could be an indication of celiac. And then some more nutrients we're thinking about: vitamin C, B6, B12, and folate. It also can be an indication of elevated LPS. So we work a lot in gut health and we're thinking about what's happening. LPS is going to be in the digestive tract, but is it systemic and is it causing chronic inflammation throughout the body? And then we're going to start thinking about gut health. If red blood count is high, we might be thinking, is there a sleep issue? That might also be indicated by looking at their fasting glucose levels and starting to put that sleep profile together. We might think about dehydration and other conditions that could be contributing to that. And then we might peek at the MCV. High could indicate a protein issue, HDL issue. Is there something going on with intrinsic factor? So digestive situations potentially that could be impacting their nutrient deficiencies. And then we're thinking about nutrient deficiencies like B12, folate, and B6. If they have a low MCV, we're going to be thinking about chronic disease, thalassemia, and other nutrient deficiencies like iron, copper, zinc, and B6.
Before I change the slide, I thought I'd tell you guys a short little story because it really speaks to how we as nutritionists look at the CBC differently than people in conventional medicine oftentimes. So I had a patient a few years back and she was sent to me by a biological dentist. She had really severe periodontal disease, but she was only 30. And she had been previously diagnosed in her late teen years with low white blood cell count chronically. So they basically told her she had an immune dysfunction. It was not something that she had any control over. So her leukopenia had progressed, and as it progressed, she made a lot of lifestyle changes because she, as we do when we're not well, often do investigation into our own lifestyle with regards to nutrition and sleep. So she had cleaned up her diet. She was eating a really clean, organic diet. She was focused on sleep. She was focused on exercise. And in her later years, her hematologist said to her straight out, like to her face, you're going to get cancer. So this woman at the time is in her early 20s. And he says, you're going to get cancer because of your low white blood cell count. It's just a matter of time. In the progression of her situation, she got married and she tried to have children and she continued to miscarry. And the hematologist told her it was due to her low white blood cell count. So when she came to me, she actually came for the periodontal disease. She wanted to know if there was anything going on that I could dig up that was affecting her gums. And so we ran a medical panel. We didn't do any other deep dig besides that. And because we include vitamin D in our medical panel, it became very clear very quickly that she was deficient. Her vitamin D was 11. So I went back to her and said, it looks like your vitamin D is really low. Can you pull up previous labs and show me where your vitamin D has been in the past? And at that time, 13 years, I believe she had this condition. No physician had ever run her vitamin D level. I hope you're all silently gasping right now. It's like mind blowing, right? So we did only that one intervention. And it rarely is this simple, but all we did was get her vitamin D up. By the time we had her vitamin D in the 50s range, she was pregnant. She ended up carrying that child in a healthy pregnancy and healthy childbirth. Her gum issues resolved and her white blood cell count was up over 4.4, I believe. It was quite literally one very significant nutrient deficiency. So to that end, it's back to, we have a unique lens and don't undercount it for sure. Okay. So in continuing with the CBC, we look at the red blood cell distribution width. Again, you're seeing a lot of the same potential deficiencies. And so you're not normally going to see just a high MCV and everything else looks normal sometimes, but you're typically going to see some patterning when it's nutrient deficiency. It's rare that the RDW is low outside of what we would consider our optimal range. And it isn't necessarily linked to nutritional factors. So when you see patterning that does not resolve with nutritional factors, I'll say we always rerun the CBC pretty quickly because it can be out of whack for a lot of reasons, a little illness, or like we said in one of the previous slides, dehydration. So this isn't something we hang our hat on unless it's repeated levels that continue to fall out of our optimal range. So don't get too hyper until you have a second test to confirm. But the last thing I want to talk about, and I don't think this is done as often, is we calculate the neutrophil to lymphocyte ratio. Because when you divide the neutrophils by the lymphocytes and you get that ratio, it does speak to the person's resilience for infection and injury. And so we do see this increase as people get older because they do lose resilience oftentimes. But where I often see this is when a person has cancer. Okay, so I try not to totally overreact if this gets up into the 4 and 5 range. But that is where I'm thinking internally, okay, I need to do a little bit deeper dive. It can be affected by nutrients. Typically what you're going to see is the neutrophils are quite high and the lymphocytes are quite low. So I'll try to address this by making sure they're eating a really high quality anti-inflammatory whole food diet, and that we get their nutrients back to optimal ranges with regards to all of these nutrients we just talked about. And if I don't see that move, that's a trigger for me that I'm going to be I'm always referring back to their primary care, but I'm going to be referring back to the primary care with a note to the primary care saying, please check neutrophil to lymphocyte ratio, and do your own investigation from there.
All right, so now we're looking at the CMP, and we're thinking about things like uric acid levels, GGT. So first on there, we're going to think about the kidney function and highlight there if there's any kidney concerns. And if that's the case, we work with clients who have had some kidney issues in the past and working on reversing that. And so we might look to something like a kidney diet that's going to help reduce these levels and see how they respond. That's also going to be anti-inflammatory, heavy in plants. We might see elevated uric acid, which we now understand is an indication that someone has maybe elevated, taking in a lot of fructose, a lot of sugar, a very inflammatory diet. It can also indicate that they have a lot of yeast or candida. And so looking at their uric acid levels, understanding their family history, we might ask if there's a family history of gout and try to assess why these might be elevated, but it can be an inflammatory marker that points you to lifestyle. We also look at elevated liver enzymes, so something like the AST or ALT in combination with the GGT, which could tell us, it could paint a picture of non-alcoholic fatty liver disease. It could tell us about the medications they're taking or alcohol use. So definitely something to pay attention to, and then match back the lifestyle questions we're asking about what's going on in their lifestyle to try to identify why this is elevated. And then we're going to look at something like GGT specifically. If it's elevated, it might indicate this person has oxidative stress. So we're thinking about their antioxidant capacity and their overall lifestyle. And then if it's low, it might indicate something like a magnesium deficiency that we want to explore a little bit further.
I was going to say, in addition to something I didn't add into this slide and I was thinking about is I've had 2 experiences with patients that had elevated liver enzymes that were really, really high. And in one case, the patient had contracted hepatitis. So they came because they weren't feeling good. So obviously, sometimes you're going to see things on a lab that's transient because they're coming to you when they're not feeling good. But in that case, obviously, we referred back to the primary care provider. The second time that I saw liver enzymes that, when we're thinking about liver enzymes in the 30, 40, 50, maybe even 60 range, then I'm thinking potentially more about chronic issues like fatty liver disease. When they're higher than that, and it seems, it shocks you a little bit, then it is often something that's acute. And in this other patient, her liver enzymes were in the 200s, and she was actually having actively over a couple of days having a gallbladder attack. And so that was a learning experience for me because I didn't realize that would be the case. But it piqued my mind to think, okay, well, when I'm seeing those elevated liver enzymes, especially when they're really elevated, I need to be thinking about asking questions about gallbladder function as well.
Yeah. Or any kind of acute flare, right? So I've had clients who are in the middle of an autoimmune flare, and then they happen to do their labs during that time and their liver enzymes were really elevated. But this is a good time to sort of get the primary care involved, because if they're working with you and you run a cash-based medical panel and now you want to run a small part again, you want to run a CMP or a CBC, you can say, hey, we don't have to totally respond yet, but I'm concerned about it. Can you go back to your primary care and ask them to rerun your CMP and CBC? So now they're definitely following through on getting their primary care involved, and there's multiple eyes thinking about this and looking at it. And then sometimes when their liver enzymes are elevated and their lifestyle starts to match this picture of fatty liver disease, we will send them back to their primary care and say, I recommend you advocate for a liver ultrasound, and let's get a really good picture so that we can understand, are we dealing with fatty liver, so that we can make the lifestyle recommendations that match what's going on in their body.
Yeah. And I guess I'll tell you one other thing, because I think we have a resource that I'm happy to share with any of you that are interested. You can reach out to us after this presentation, but we have a diet that we specifically designed around poor kidney function when somebody's been diagnosed with stage 1 through probably 3 kidney disease. This is really effective. So it is a very low protein vegan diet. It's based on basically reducing all of the pressure on the kidneys. And we don't work with a ton of people that have kidney disease, but I would say now between us, we've probably worked with maybe 5 or 6 people that are in sort of a critical condition with this. And most recently, just in the last 2 months, I had a patient who had a heart attack last year. She was really motivated. She ended up hospitalized with COVID again this fall. And in the last year, with all the medications that she's been given with the heart attack and then the effects of COVID, her kidneys really, really were damaged. And so we were looking at a glomerular filtration rate in like the 30s when we got her labs last month. And so she went on this kidney diet. And when we just retested last week, she had restored full kidney function in a matter of really a month. And so she was committed to staying on it. But I think her primary care provider was pretty blown away. And it's just a good reminder that with the right nutritional approach, your tissues actually heal, even when we think that it is something that you can't come back from. So that's a resource. It's a big ask. You're telling people to eat a very, very, very restricted diet for a period of time, but it's a very effective diet. Okay. So when we run an iron panel, you guys saw at the beginning, we're looking at ferritin, we're looking at iron, we're looking at transfer and transfer saturation, UIBC, TIBC, because we want to see not only what the circulating iron levels are, which we don't care quite as much about, but we want to see the storage of iron as ferritin, and then we want to make sure there's no issues with transporting iron around the body. So it's not totally abnormal for us to see hemochromatosis. When we see a high level, we're thinking hemochromatosis. I didn't write it in here, but you can have something that looks kind of like hemochromatosis and it's just acute inflammation. It is an acute phase reactant. And the reason that we understand this to be so is because in really high levels of inflammation, the red blood cells can basically explode, releasing ferritin into the system. So with many things, if you have a high ferritin level, typically you want to retest after a period of time, 30 days or so, to see if you still have a high level. And hopefully you're working on inflammation during that period of time. So if you do find that somebody has hemochromatosis, what we're thinking about is giving them zinc with their meals. Zinc can help block the absorption of iron, and we're typically asking them to give blood anywhere from once every 6 weeks to once every 3 months, depending on the level of their hemochromatosis. And we're typically going to retest that with genetics, genetic testing to confirm, or send them to a hematologist to do that. When it's low, we're thinking about, the most common cases are menstruating women that maybe are eating iron-containing foods, but they can't keep up with their blood loss, or they are not eating a high amount of iron-containing foods and they have blood loss. So we're going to look at diet. We're going to look at menstruation. We're going to look at absorption, though. And I think this is one of the things that we feel is really, really important, is looking at the hydrochloric acid. So are you breaking down the food that has the iron in it? And then what's the state of your intestinal wall? And are you actually absorbing this properly? So not just, it's great to do sort of a nutrition check and have somebody do a food diary and really see if they're getting enough iron in their system, but paying attention to other factors that may be pointing the arrow towards poor digestion and poor absorption. In our clinic, it's very common for us to see very low ferritin levels. And I would say, just so everyone knows what our range is here, if people are dropping under 75 in ferritin, we're paying attention. If they're getting into the 50 range, we're really we're really paying attention. And then when you get into the 30 range, we're doing iron infusions for most of our patients that are in that range to get the numbers up, because it's very hard to get the patient back to optimal ranges at about 75 or over with oral alone, and people have GI issues, et cetera. So we do have that benefit of being able to give people venifer infusions here to bring those levels back up. And we do see that their symptoms are linked to ferritin over and above being linked to anything in their CBC or their circulating iron levels. So that's the marker we most depend on. Am I missing anything there?
No, and I think what some of the things we typically see when we start to wonder if ferritin's a factor is we ask people like energy, anyone who has energy issues, and they possibly are cycling and have blood loss, we're really thinking about iron and ferritin. And then we also ask people like, are they getting winded when they're walking up steps, heart palpitations, all kinds of symptoms when you're going through your intake process that you're like, has anyone checked your ferritin? And it's pretty amazing how many times no one has checked their ferritin and they've been in and out of providers' offices, kind of like vitamin D. And then it's also really interesting how many times they've had a primary care check their ferritin. I've seen ferritins at a 12 and their providers said nothing about it, didn't really do very much. Maybe they tried a little oral iron, they moved on, no one retested it. So sometimes it's really simple and it can be those big, these key nutrients that we have to look out for.
I had a patient this last week whose hemoglobin was 11 and her ferritin was a 7. And she's a 46-year-old woman in perimenopause having very heavy bleeding. And what we always try to do if we can in these situations is get the primary care and maybe a hematologist on board so they can prescribe an iron infusion at like 1,000 milligrams. So it can be done in one shot and under insurance versus us having to do it at 200 milligrams per infusion, and they have to have multiple, and then they are cash based. And so I did send her back to her primary care and her primary care said, oh, it's fine. I mean, your like hemoglobin's a little low, but it's just your period.
Continue to be winded every day.
And you have to take a nap every single day at 10 a.m.
Yes. All right. So some of the key, big nutrients we're looking at when we look at our panels, we're testing vitamin D, as Megan mentioned, can be really valuable. We're testing B12. We're going to look at zinc and copper and magnesium. And so in our clinic, we focus on these in our initial testing, but we also sometimes get to do cellular level micronutrient testing later. But we find that these are sort of the big pieces that we can start to put the picture together and understand what's happening. Our panel also includes a zinc copper ratio. So understanding the relationship between zinc and copper can be really helpful because you want to protect that relationship. And so these are definitely key nutrients that help us start to paint the picture of what's happening in their lifestyle and what's missing.
And I put the MCV in parentheses after the B12 because oftentimes we'll see that circulating B12 looks fine because they're taking a B12 supplement or they've eaten something that has a high amount of B12. But I think we both are pretty adept at confirming or at least continuing the investigation by looking at the CBC. If the CBC looks really good and the B12 is really low, we have pause. If the B12 is really high and the CBC looks poor, then we have pause because those transient circulating markers are a little bit hard to rely on. Okay, we do hormone testing. It's really interesting because if you're familiar with ranges for hormones, they're like vast and wide, right? So you have to really decide what you can deduce from these markers. So if we're concerned about hormone issues, we have the person do their blood test on the 18th or 19th day of their cycle if they're on a regular 28-ish day cycle, because those are the values that are most utilized in conventional medicine. So if we know we want to send this back to their OBGYN or, their primary care or whatever, we want to make sure it's on that day. That said, 9.9 times out of 10, we are basing our decisions around reproductive hormones on symptoms over and above the laboratory markers, because the symptoms are going to speak much more loudly and be more accurate. One of the most common things, though, that we do see is high levels of estradiol matched with symptoms that are associated with high levels of estrogen in the system. If we see that, and if the patient fits the bill symptomatically, or let's say the patient fits the bill symptomatically and we don't see it, actually, either way, we're going to support optimal liver function. So we're going to be thinking about micronutrients that are very specific to phase 1 and phase 2 detoxification. Right now, we very regularly use a supplement by Metagenics called Axis Endo, which we find to be really, really effective for bringing estrogen down. In part, it's because it has the micronutrients for liver detox. It protects the liver cells in that in-between phase in phase 1 and phase 2, but also has calcium D-glucarate in pretty high levels, so it binds the estrogen. We also find that it's absolutely critical when we're trying to bring estrogen down or get it in balance with the other sex hormones that we're using a very high fiber diet, very specific to soluble fiber. And because I have a soluble fiber blend that I developed, we typically are using that in clinic in tandem with the diet, because what we know is that as the liver is trying to get rid of estradiol or estrogens actually, that the body no longer needs, it's going to attach it to bile, it's going to secrete it into the small intestine. And unless it's bound to soluble fiber, it's reabsorbed into the bloodstream. So you're trying to bring estrogen down, it gets reabsorbed, brings estrogen back up over and over and over and over, multiple times a day, actually. So the consistency of high soluble fiber in the diet is really, really essential for a woman that's experiencing any type of hormone symptoms, such as really severe PMS or really any PMS, or if they're moving through perimenopause, and we know that those hormone levels are kind of going all over the place. Generally speaking, I'll speak for myself. Generally speaking, outside of those symptoms, which I should say extends to like migraines when they're hormone related, weight gain when it seems hormone related, I'm not doing a lot nutritionally with testosterone or progesterone outside of putting people on very blood sugar balancing diets that are high fiber and whole food. So just logical stuff, right? I don't do a lot with herbs around hormones. And that's in part because we have really strong hormone providers in our clinic that I feel are more adept. I do address DHEA, and we want to see a DHEA above 100. When it's very high, I'm thinking about adrenal function and I'm thinking about stress. So we may do some things around balancing their nutrition for stress, you know, again, back to keeping a blood sugar balancing diet, high fiber, whole foods. But I'm also thinking about making sure that I'm covering my bases with their adrenal function. So I have to go back to symptoms and say, okay, does it sound like the adrenal glands may be a specific issue? And then I'm going to refer them back to primary care, to another specialist. When it's low DHEA, we're talking typically around chronic stress or chronic inflammation. It's been going on for a long time. And we are able to give people DHEA because it's over the counter. So typically we'll start with 5 milligrams or maybe 10 milligrams, depending on how low it is. Again, we want it over 100. Ideally, if you're in your 20s or 30s, we want it much closer to 200. So we're going to start them by taking that supplement in the morning. And we're going to do, again, all of the other things to keep the pressure off of the system nutritionally. Cortisol is a little iffy on a blood test, because it's looking at total cortisol levels. So if we're really concerned and if their symptoms fit the bill, so they're saying like, I have no get up and go in the morning and we've done everything else and their cortisol levels are low, we may do a retest through urine or it's misspelled, but saliva. And so we may be addressing those pathways with nutrition or supplementation after we've confirmed it. I have had many patients that have true medical issues with their adrenal glands. And so when I pay attention to cortisol and I see repeat tests, and after about 30 days, nothing is working that I'm doing, I'm going to really reinforce that I want them to get to an endocrinologist via their PCP.
Yeah, and I think it's good to remind people that hormones are downstream from everything. So if you have someone who walks in an inflammatory state and they don't eat a really great diet, like there's some really basic starting points. So if you don't have adequate energy and nutrients, you're not going to create hormones. If you don't have a proper environment in the body and in the cells, you're not going to create the hormones you need. And if you're not getting rid of toxins, which you're going to support the liver, and that, you know, things have to get out through the stool, the urine, through sweat, then you're not going to create adequate hormones. And so sometimes when you start to see this hormone dysregulation, going back to the basics of like really fixing those things is going to be the starting point, and then really seeing what's left.
Yeah, and you'll find, as I'm sure you already have, that many people that have any type of hormone dysregulation in their childbearing years are often given birth control, which just fully masks the symptoms, but does not do anything to address the underlying issue. One thing I didn't mention that we see, and we don't see it as often, but we'll see women or girls that don't have a period at all because of their low body fat. This is common with athletes. We are looking at supporting their macronutrients as well as their micronutrients to make sure that they're not only getting enough energy, but they're getting enough fat to actually be able to produce estrogen. And interesting research has come out with teen athletes that while, yes, they're often put on birth control, unfortunately, they're going to be losing bone mass if they're not having a menstrual cycle. So we do punt them over to our medical providers, because in lieu of birth control, which does absolutely nothing for your bones, doing some hormone replacement for these athletes to give them actual estradiol will give them a cycle again, and it will also support and protect their bones.
All right. And now we're talking about glucose, so blood sugar. We love to talk about that around here. So here are some of the major things we're looking at. We're looking at A1C, we're looking at fasting glucose and fasting insulin. And so that's a great reminder. We ask them to go in and do this comprehensive medical panel fasting in the AM, because we want their AM cortisol and we want these markers while fasting. And so if we see an elevated A1C, we're starting to think about this person needing to be on a low carbohydrate diet, considering using something like a CGM. We use a lot of CGMs in our practice and have had a lot of success with that. And so considering things like that, if a CGM is out of their budget, we can also use things like finger pricking. So finger pricking when you're waking up in the morning with a glucose monitor that they can get from their local drugstore that's inexpensive. They can finger prick before and after meals and really get a sense of what their blood sugar is doing and start to track and see patterns. If their A1C is elevated, we might be thinking about supplements like berberine and chromium, and really thinking about blood sugar regulation and starting to educate them a little bit more on the balance of carbohydrates matching their activity level and what they're doing in their lives. Then from there, we're going to look at fasting glucose. If we see a high fasting glucose, we're thinking about things like sleep apnea and carbohydrate intake and what's happening maybe before they go to bed. What kind of things are they eating in the evening or late into the evening? And then if we find low fasting glucose, we're going to be thinking about overall diet and insulin levels. With fasting insulin, if it's low, we're thinking hypoglycemia, trying to match symptoms to that, understand what kind of symptoms they experience throughout the day. We might be thinking about the balance of protein they're taking in. And then we also would think about high fasting insulin, if really what's going on. Are they spiking their blood sugar often, trying to educate them? So you want your insulin to be under a certain number. And if you have this high insulin, that means you're constantly taking in this glucose that doesn't match your energy level. And now insulin's coming out trying to protect you from it. And then eventually you're going to lead to storing excess glucose as triglycerides and fat. And so a lot of our clients are coming in and they're trying to do weight loss. And so if we start to see elevation in any of these numbers, we're going to start to educate them on what is blood sugar, what is happening in their body, and help them bring this down with all of these various tools.
You're going to have a really hard time getting somebody's glucose under control if they have sleep apnea, whether they're overweight or normal weighted. And I think one of the things that we spend a lot of time educating our patients on how the body metabolizes glucose in the diet or carbohydrates in the diet. And the reason I'm passionate about that education is because we have demonized carbohydrates and we have spouted so much information about carbohydrates in general, basically discourse on social media and everywhere else, that there's just a total misunderstanding about what it is, why we use it. And so one of the things I say to people is, when I think about consuming carbohydrates, it is like putting gasoline into your car. You need to drive your car to deplete your fuel tank before you put more gasoline in your car. Otherwise, it's going to spill over. And glucose isn't something that you can consume, or carbohydrates aren't something that you can consume without having either a cell that needs it for energy to make energy, or without it increasing your average glucose by attaching to a red blood cell or by turning into a triglyceride. Now, granted, we know it also becomes glycogen in the liver. We all know that, but I try not to get too into the weeds with people. But what I say to them is, carbohydrates aren't good or bad. They're just not good. They don't but they're energy, they're fuel. They allow you to generate energy. So when you're sitting all day long, you don't need nearly as much gasoline in the car as when you're moving all day long, right? And so this is why, a teenage athlete can consume massive amounts of glucose and have these beautiful glucose levels. And you see, I did this for my poor son. I made him, he was 16 at the time, now he's 17, but I made him wear a continuous glucose monitor. And he's such an active athlete with such a high amount of muscle that it did not matter what the kid put in his mouth, his glucose never moved. It was just beautiful. And then my 15-year-old daughter ate a pancake and would have a glucose spike, right? Because she just doesn't have the same metabolism. So I think it's really important that people understand that if there's an overage of glucose on a regular basis, they have health risk because it is meant to fuel the car. You've got to drive it. It's my tangent.
Yeah, it's important.
Okay.
So now, is this you? Oh yeah,
maybe this is you. Okay.
This is you.
So all right, let's talk about lipids. Okay, so here's I did get to monologue on another story again. So there is a way that I explain this to people because I think it's important because we talk about bad cholesterol and good cholesterol. We do a total cholesterol, LDL, HDL. Like I said, we do ApoB and we do Lp(a). You're going to see a higher ApoB, which I explain to people is like Velcro on the outside of these cholesterol molecules, and it does get stuck in the arteries, right? So you're going to see a higher level when a person has high LDL and high Lp(a), because both of those molecules can have ApoB, and that is where we see risk. That's a very important marker. But if the total cholesterol is elevated, I need to still see the ratio of the LDL and HDL, but I'm going to be thinking about a Mediterranean diet that's lower carbohydrate. We also use Prolon fasting mimicking diet that was developed at USC because that very quickly reduces total cholesterol and LDL. But when I'm explaining this to somebody, I tell them that your liver makes LDL. It's the Amazon delivery truck. It is meant to go out into the vascular system and drop off cholesterol all over the body. And your body uses that cholesterol for good. But if you over-deliver, if there's too many packages, it does become dangerous. And so HDL is a recycling truck, and it is sent out by the liver to pick up excess cholesterol. This is why we need that ratio to be in check. But the bigger question to me, if LDL is elevated, is why is it elevated? Is it your diet? Sometimes it is, and we need to address diet. Sometimes it's inflammation. Your body is going to trigger your liver to make more LDL when you have an infection or inflammation because your body actually uses cholesterol to make white blood cells to respond. So we're thinking about that. We're thinking about liver function. So to me, cholesterol levels are the tip of the iceberg for more questions. They are not the stopping point. Now we know an anti-inflammatory high fiber diet, because fiber does bind, soluble fiber does bind cholesterol in the intestines, and it helps you excrete it through your stool. But we know that a diet that's high in antioxidants, lots of plants, lots of fiber is going to be your best case scenario here. But this is going to prompt us in our clinical practice to make some dietary changes with this person, look a little deeper to see if there's other inflammatory or infectious markers. And then we are likely going to refer them based on other markers and based on their history and family history for a CIMT, which is the carotid intima media test, because we do that in our clinic. And that is an ultrasound of the carotid artery. And then that allows us to know how deep are we into this problem, right? And we will match the intervention based on how far along they are in potential cardiovascular risk or disease. Anything you want to add?
No.
Okay.
All right, the lovely thyroid. So we really want to get a picture of what's going on with the thyroid, and that can point out a lot of things for us. And so we've talked about our comprehensive panel. So all of these markers, including the antibodies, so looking for anti-TPO and anti-TG to see what's happening. And so for us, there's a lot of things you can do if you see activation in the thyroid. So one thing that I do note is it's often the first place I start to notice autoimmune activity. Mm-hmm. And it doesn't necessarily mean that someone has a full-blown autoimmune disease, and that's not our job to tell them, but it is an opportunity to start to explain to them, if they have elevated antibodies against their thyroid, that we're having autoimmune events in the body what does that mean? And explaining that to them understanding that it's a signal that your immune system is overactivated and now it's wanting to attack itself. And so this is a great motivator to do diet and lifestyle changes to really reduce these autoimmune events. And we have seen clients that come in and they have this antibody activity, and then we start to do some of the things like an anti-inflammatory diet, get their macronutrients in order, protein and carbohydrate intake. We do stress support, address micronutrient deficiencies, and we do see antibody levels coming down. If I see elevated antibodies, I will still punt them back to their primary care or one of our providers and say, this is a great time to have a conversation around this. But it is a great signal. Or if we see elevated TSH, we start thinking, okay, the thyroid's looking for something and it's not happy and it's not getting something. And so it's sending out this signal. And so my job is to try to do everything to bring nutrients into the right place and the diet into the right place to help the thyroid become more successful at whatever it's trying to do. So we might notice things like in zinc or selenium or iodine needs or vitamin A, C, and D. We might suspect if we see elevation in any of these markers that they need to get a thyroid ultrasound. And we will educate clients on, okay, go back to your primary care. And they might not be that concerned, but I recommend you ask for thyroid ultrasound and learn things about your thyroid and get the full picture around what's going on with the thyroid.
We recommend thyroid ultrasounds much more early on than most people. And it's basically anytime there's antibody activity. And that comes from a place of knowing that, A, it's important to get a baseline of whether or not there's structural problems. If the antibodies are an indication that your immune system is destroying this gland, we need to know about that. And if it's not, great. Now we have a baseline. It's $100 to go to our local, what's called RAIS, where you can get ultrasounds and imaging to have this done. So it is typically within people's budgets to have that data. I have had 3 patients have thyroid cancer when I've asked them to do that, and their endocrinologists have said I would have never checked because they palpated and felt nothing. So we're proactive over here. So I am a fan. And then to this, just to speak to biotin, this is really important. If a person has a thyroid issue, oftentimes they have hair loss. Then they take biotin. Then they go in and get their thyroid tested. Biotin indirectly changes the markers you're going to see, but not the thyroid function. So you have to have your people stop taking biotin a week before they have the test in order to get accurate markers, because then you're potentially treating something that isn't actually an accurate indication of what's happening with the thyroid. Okay, so we include IgG, IgM, IgA, IgG for baselines. It helps us understand if there's any activation or if there's any deficiency that may be affecting the body's ability to actually produce these markers. I'm not going to speak to all of this because you can read it on the slide, but under IgE, this is a nice marker for knowing that somebody's reacting to the environment inside their body or outside their body from a histamine perspective. And so this allows us to sort of confirm some information, and we'll typically do a deeper dive around allergies, parasites, and then candida overgrowth will often also drive up IgE. Again, I won't go too far into this, but these are just nice markers to recheck, especially when you're concerned about immune function or immune activity.
All right. Inflammation. So in many ways, lots of markers we already looked at are inflammatory markers. So we talked about cholesterol and other various markers, but these are some that are specific and we're thinking about inflammation. So homocysteine is really important. So essentially telling your client when they have elevated homocysteine, which typically is anything above a 9, that this is a signal to your body to turn the wrong genes on and off that create disease. And so it's going to tell us a lot about nutrient status and inflammation. And so if you see an elevated homocysteine, you want to know about it, you want to bring it down, and you're going to use tools like folate, B12, B6. We have a great product, Homocysteine Resist, that we like to use with our clients. So you want to watch that, you want to try to bring it down, you want to recheck it in 60 days. HSCRP, general marker of inflammation. It's not always going to tell us where the inflammation is, but it's going to tell us that someone is inflamed. And so that's a great data point to help someone understand, okay, you came in, you have all these symptoms, you have a lot going on, and your body is showing us that it is inflamed. And then we do elevated, we'd look at oxidized LDL. And if that's elevated, another marker of inflammation. So it's not just that they have LDL, that it's oxidizing and creating this stress in the body. And if that's happening, that definitely tells us they're probably eating an inflammatory diet that is not rich in antioxidants. And so we really have another reason to help them focus on this diet that is fiber rich and rich in plants to address these elevated levels.
Okay, so those are all of our markers. We like to say as much as possible, especially in our clinical immersion program, when we're talking about, we take a risk by interpreting a medical panel. Okay. So we cannot diagnose, right? We cannot legally treat. You're going to see things on a medical panel and you're going to be thinking, oh crap, that's a diagnosis, right? But you can't diagnose. You have to send them back to the PCP. It's critically important that you not only verbalize that these labs need to go to your primary care. You need to go through them with your primary care, make sure they're not seeing something different than I'm seeing. But we also write it in our chart notes. And I try to collect the primary care provider's name and fax this to the primary care provider. So like all of the boxes are checked with your liability if you're going to be interpreting medical labs in your practice.
Yeah. And you're going to catch this in many places. It's in our intake agreements. They sign that any labs that we run, because we are functional nutritionists, or you're going to share with your primary care. We put it in every chart note to really make sure they understand our role.
Okay.
We got
There
lots
you
of
go.
questions.
Ready for questions.
Okay. Anastasia is asking, how would you test for copper, magnesium, and zinc blood levels? ? I was told not as informative as a hair mineral test.
Yeah, we do not use hair mineral testing because at least our understanding is that it is not necessarily an accurate marker based on the evidence. However, if we're really concerned about this, based on the patient's symptoms, we will do intracellular white and red blood cell testing because there's better evidence that those levels are telling us about the savings account in the body, really. Circulating levels change all the time. Now, plasma zinc and RBC magnesium are strong indicators of overall status, as is vitamin D. But yes, there are some questions around the plasma levels or the serum levels of all of these.
Right. Next question. They say iron infusion could increase oxidative stress on the body as iron oxidizes very fast. How would you determine if it's safe or not for a person?
Well, we have to consult with medical providers when we do this in our clinic. So we do that. However, I will say this does not almost ever come up with anyone when they have a ferritin that's low enough that it's causing them symptoms. We find that we infuse people and they feel almost immediately better. So I guess we just don't focus our energy into that. We're trying to make sure that their oxidative stress is, managed in every other way that we can manage it. But the benefits of an iron infusion when you have extremely low ferritin levels are, they outweigh the risks in my opinion.
Yeah. I mean, yes, if you're walking around and you're having trouble moving oxygen around your body, you're going to have a different issue.
Yeah.
All right. Cynthia's asking, reference the perimenopausal women's HB and ferritin levels. How do you engage / interact with a primary care who dismisses the issue?
We don't.
Yeah.
I mean, we have a network of providers that we have good relationships with in Portland. We've worked really, really hard to develop those relationships. So if a person is hitting a brick wall with their primary care, we may refer them to another primary care, or we may refer them to an OBGYN, or because we have this situation because we're in our own clinic, we may be saying, okay, scrap that, come see one of our physicians or our nurse practitioners. They'll do an assessment, they'll do, medical liability, and we'll just deal with it here.
Excellent. Do you have any cases to share that required correction of zinc copper ratio?
We see low zinc a lot, especially in the context that we see such high numbers of people that have overgrowth of candida in their GI tract, which will sequester zinc. So, zinc is and then we see a lot of intestinal permeability. So we're using zinc carnosine in those situations, but we do a lot with zinc. And I would say it's so common. I can't even think of a case study as much as just saying that we're looking to move that ratio to the kind of commonly accepted 10 zinc to 7 copper sort of ratio. But I have seen the RBC regulate pretty regularly on that, especially when we have ruled out iron. Do you have anything specifically with zinc?
I mean, I can't say that it's been the one thing that has moved everything for a client, because by the time we're getting to that level, to that detail, there's a lot of other things going on. But yes, we have clients coming in and that ratio is off, and we're going to want to look at that and possibly retest after we address it. So we might, whatever we're trying to do, it might be bringing in copper and not zinc at the moment. It might be bringing in zinc and then making sure we're bringing copper in later. So we're playing with those levels, but I can't say I have a client that presented that was the only thing going on.
And if both levels are low, I'm normally giving people a zinc copper combo, because I don't want to give them zinc and then really suppress their copper levels. Where I'm doing zinc only is when the copper is elevated and the zinc is low, and I need to bring that zinc up above the copper.
All right. Is DHEA over 100 consistent regardless of age, peri or postmenopausal?
We want it over 100 for absolutely everybody.
Yeah. And there's also really good research in the menopause world around all of the benefits of supplementing with DHEA.
Yeah.
I think it was the Polish menopause group just wrote a paper on that you can find in the PubMed, or you can email us and we can share. But amazing amount of symptoms that you can mitigate that people are experiencing in peri and postmenopause by getting their DHEA levels up. And sometimes we're aiming to go above 200. It's not always just over 100. We might be trying to get above 200, but there's a lot of benefits to taking DHEA. Of course, with women, you're going to start at the lower dose.
And you're going to see it naturally decline. If you're working with a woman that's 75 years old, she's probably going to have a low DHEA, and she's going to feel a lot better when you get it over 100.
All right. Michaela is asking, in your experience, how willing are clients to pay cash for blood tests? And once I order blood work for a client through Vibrant America, where do clients go to get their blood drawn majority of the time? Like, do they mainly go to a specific local blood draw lab, or do a mobile phlebotomist come to the client?
Yeah, it sort of depends on where they're located. So we have a cash-based practice. And so our clients are very willing to pay cash to do blood draws when they need to. Megan and I also attract a lot of chronic disease, chronic symptoms. So by the time people get to us, they've had a lot of providers, they're not feeling better, and they're motivated to spend money to feel better if you help them understand the value of something like a medical panel. And so it hasn't been incredibly hard to convince them to do that. But then sometimes if cost is prohibitive, we will encourage them, then go back to your primary care, advocate for them to order this through insurance. Even with Kaiser, which is not always easy, we've had some clients who have been successful at getting some of these markers. With Vibrant America, if you work with them, you can order these labs as a nutritionist, and they will help you identify on their website. If you go on Vibrant America, there's a place where it says locate a blood draw site, and you can put in the zip codes that you typically work with, and it will list some phlebotomists. You can also email your rep at Vibrant and say, I'm looking for someone in this area. What are some of the options? If they live in a smaller area, that's not like a major city that has a lot of phlebotomists, or a small town, they can also take the kit that will be shipped to them, and they can take it to a local hospital or anywhere blood draws are done. And they can ask, will you do a complimentary blood draw? And some of those places will do a complimentary blood draw for not charging them anything at all. Some might have a charge. And so that's also an option if you have someone in an area like that they can find somewhere where they do blood draws who might be willing to do their kit. They prep their kit, they mail it.
Excellent. We have many more questions, but we're out of time. So maybe what I'll do, if it's okay, Megan and Ashley, maybe I'll send you the questions.
Sure. Yeah, that'd be great. We're happy to respond.
I'll answer them in the follow-up email if that's okay.
Yeah.
Awesome. And anything else from the two of you? Do you have?
I
figured another slide there.
Yeah, so we just wanted to let you know how you can reach out to us. So if you want to learn more about learning with us, we have our website, learn@bioloungepediatrics.com. There's a lot of different ways you can learn alongside us in various capacities, so you can visit that website. If you want to reach out and you're interested in some CNS supervision, you can email Megan at this email address. We have a free newsletter every month. We send out, sometimes twice a month, we send out case studies and clients we're working with. We'll share with you what we did, how we approached it, what was the solutions that created the resolution for our clients. So if you want to follow along and get more familiar with how we practice, you can go to learn@bioloungepediatrics.com/clinical insider. And then if you have any questions that we didn't have a chance to get to and we don't answer in our email, you can email us at learn@bioloungepediatrics.com. And if there's ever a topic you're interested in us discussing in the future with the ANA, please reach out and let us know, and we can potentially consider having a conversation with Amy and doing that in the future.
Awesome. Thank you so much. There was so many questions, so I'll try and get everyone's answered, and we'll follow up with an email. Thank you so much. This was great.
Thank you. Thanks for having us.
Have a wonderful day.